We are still trying to figure it out. What's the ideal means for identifying which patients warrant invasive coronary angiography to define the extent of CAD and the need for revascularization? Well, the October issue of JACC Imaging wonders whether it may be time to pull the RIPCORD. The paper, does the routine availability of CT-derived FFR influence management of patients with stable chest pain compared to CT angiography alone? And this is the FFR-CT RIPCORD study. I am with the first author of the paper. This is Nick Curzen, who is an MD, PhD, and Professor of Interventional Cardiology at the University Hospital Southampton in the United Kingdom. Tell us about the RIPCORD study.
So the FFR-CT RIPCORD study was a study in which we compared the management of patients presenting with chest pain who had CT coronary angiography. So they got anatomy, an anatomical-based assessment of their anatomy, for coronary anatomy, using CT angiography. And from that CT angiography data set, using the HeartFlow FFR-CT system, we're able to derive the physiology in each of the vessels. So the question the study was asking is, what effect on the angiogram-derived management of patients with chest pain from a CT angiogram would there be if they had FFR-CT physiology at the same time? And so what we did is we took 200 patients who had presented with chest pain who had a CT angiogram, and a group of 3 experienced interventional cardiologists assessed the CT angiogram and decided which lesions were significant and made a consensus management plan for each patient based on that angiographic assessment. There were 4 options: optimal medical therapy, PCI, bypass surgery, or we needed another test because we weren't sure whether they were ischemic. Once we had committed to the angiogram-derived management strategy, we were then shown the FFR-CT data derived from that CT data set, and we were then we then made another management plan based on that FFR-CT data set. And the outcome of the study was that 36% of the 200 cases, the management changed because we had FFR-CT available. And the reason for that change is that if you compare the significance of lesions in these patients based on the angiogram alone and use an FFR-CT to decide whether they are ischemic or not, you find that there's a mismatch between the anatomical data set and the physiology data set in exactly the same way as we've seen before in invasive studies using invasive angiography and invasive FFR. In fact, this study was based on another study that I did a few years ago, doing exactly that in 200 patients, where we looked at the angiogram-derived effect of management of 200 cases, and then we performed FFR invasively on all of those patients in all their vessels. And then we made a second management plan, and we found that in that case there was also a substantial change in management. So what this study, FFR-CT RIPCORD, has done is it's shown non-invasively that we can see the same effect on management as we did invasively. And this is a really exciting result.
Yes.
It's proof of concept, that's all. But what it tells us is that we can get a more refined and personalized therapy for patients with chest pain non-invasively using the FFR-CT technology.
Now, as reimbursement starts to shift to value-based care, we really are going to need to determine whether FFR-CT improves clinical outcomes. So what needs to be done next?
So it's a really good question. I was involved in the platform study, which is a FFR-CT study comparing FFR-CT-derived management of patients presenting with chest pain with routine care. It was not a randomized trial, but it did show that there was a reduction in the number of patients who needed an invasive angiogram, and also a reduction in the people who had an invasive angiogram who turned out to have no significant coronary disease in the FFR-CT group. And it showed that it was dominant in terms of resource utilization. But the answer to your question, in my opinion, is that we need a randomized trial. And I'm currently working on a randomized trial called Forecast, which will do exactly this. It will be a 1,400 patient randomized trial where patients presenting with chest pain in the UK, where there's quite a homogeneous system for assessing them called rapid access chest pain clinics, will be randomized to routine care or to FFR-CT. And that trial is powered to look at resource utilization and clinical endpoints. And I think that should be the definitive answer to your question.
I mean, based on NXT and RIPCORD, what is the take-home message at this time?
For me, the take-home message is that we look as though we may have a technology on our hands here that could change the way that we assess people up front who present to us with chest pain. It has the potential, this technology, in my opinion, to become a default one-step access for patients with chest pain where they get a CT angiogram, they get an FFR-CT, and we can determine their management. It's a very exciting technology. Personally, I don't think it's quite ready for the clinical frontline until we have this randomized trial, but I think it's very exciting.
Have you done any financial analysis? Is there any data yet?
So from platform, there's financial analysis, and as I say, particularly in the group that would have had an invasive angiogram in routine care, FFR-CT was dominant. But I think we need a proper randomized trial with all comers. So our plan for forecast is that we recruit almost everyone who comes to these rapid access clinics in the UK, because there are very few exclusion criteria. And then we'll know for sure in the real world whether FFR-CT is cost effective.
Yeah, because that's really important too here in the United States, and I'm sure it is over in the UK too. Yeah. You really need to know that information.
And I think the diagnostic accuracy of this test is, for me, that's settled. I'm happy that it's got a very high degree of diagnostic accuracy, but as you say, it's a question of resource utilization, I think.
Well, thank you very much, because this is a great study, and good luck. When you get some data, would you come back and talk to us again?
Of course, thank you very much.
This is for JACC Imaging, and it is the October 2016 issue for CardioSource World News and CardioSource World News Interventions. I'm Executive Editor Rick McGuire.